Yes, please. Right. So if you have read and understood, considering it communication skills patient, kindly begin.
Okay. Good evening. Hello. Good evening. I'm Dr. Ajayi Abbas. I'm a senior SHO in working for Mr. Mann. I'm calling to speak to Mr. Smith to seek his advice for a patient who had surgery yesterday who had a right hemicolectomy for a cecal tumor yesterday with a liver biopsy for suspected metastasis. I'm calling because the patient is currently oliguric, and can I check who I'm speaking to, please?
Yes, I'm Mr. Smith speaking. Can you please summarize your case?
Okay, sir. My patient is a 69-year-old woman who is first day post elective right hemicolectomy for a cecal tumor and also had a liver biopsy of the same sitting for suspected metastasis. She's having a persistent tachycardia and hypotension, blood pressure of 90/60 millimeters of mercury, with a core temperature of 37.5 degrees Celsius. Post-operatively, she was post-operative PCV was 10. It dropped from the previous 12 by 2. She has received 2 units of blood intraoperatively. She has a serum creatinine of 416 micromoles per liter and urea of 16 millimoles per liter. Echocardiography, chest X-ray, and abdominal findings were normal. However, her urine output was noticed to be 10 to 20 mils per hour in the last 8 hours. She has received only 1.1 liters of normal saline since post-operative period.
Okay, so what do you think the cause could be for her oliguria?
So, yes, sir. I think her oliguria is likely because of her dehydration. Also, because there's reduced. She had just 1.1 liters of fluid in the post-op period. Despite Yes, ma'am.
Yes, please continue.
Yes, ma'am. She's also hypotensive. With as a result of pre-renal reduction in blood flow, that may also account for the oliguria.
But you did say that the patient received 2 units of blood, right? During
Yes,
her
ma'am.
operation?
Yes, ma'am.
Okay. So do you think the patient is bleeding now?
Yes, but I'll monitor the vital signs. Considering the patient has tachycardia and she also has hypotension or BP of 90/60, I would monitor the blood pressure and the pulse rate continuously. If I notice significant drop, I also monitor the HP. If I notice a significant drop, and with serial abdominal examination, if I find any signs suggest bleeding, I will let you know.
Okay. So what are your plans of action for this patient?
Yes, sir. I will monitor the patient as a using the CRISP protocol. I will assess her airway to ensure airway is patent. I would check her breathing to ensure it's normal. Then I would pass it to eyeball cannula and resuscitate and restore the volume, the volume depletion she's having, and to ensure that. And then I'll monitor the vital signs. Pass the urethral catheter. Monitor the urine output from the urethral catheter. I would also pass an NG tube to decompress the stomach, and then I would take samples for serial serum electrolyte, urea, and creatinine, and bloods. I would then monitor the patient, and I'll update you subsequently.
Do you want to involve anybody else in this management?
Yes, ma'am. I would involve the I will alert the IT registrar ahead ahead, and also involve the nurse on duty. I'm also calling you, who's the consultant on call, about the current stage of the patient, and then I would also basically those color.
Why do you think the blood transfusion was required perioperatively?
Yes, ma'am. Because I think the patient is the reason why the blood transfusion was required was because of the significant blood loss intraoperatively, and there was a drop in HB intraoperatively, assisted hypotension.
How would you start the patient's fluid challenge? What is the dose that you would use for it?
I'll commence intravenous normal saline, 1 liter start, and then observe over 30 minutes, and then I would observe if there is a response, assessing with the blood pressure, pulse rate, and then I would also want to do ABGs. If there is no response in the initial challenge, I would try another one again. I would also give another 1 liter normal saline again.
Do you think this patient requires... do you think this patient requires high dependency unit transfer?
Yes, ma'am. Yes, ma'am. I would, if the patient does not respond to the fluid challenge, I would transfer the patient to the HDU, and then I would insert a central venous line and monitor. The blood shows HB dropping again. I would request for another transfusion.
Okay. All right. Okay. Thank you, doctor. If you could just summarize your...
Thank you, ma'am. I have discussed a 69-year-old woman who is 1 day post elective right hemicolectomy for a cecal tumor with liver biopsy, who has tachycardia and hypotension with a drop in HB and oliguria, and a mildly elevated serum creatinine and elevated urea, following who had just 1.1 liter in the last 24 hours. I have discussed with you my possible plan of management, and my intention to transfer the patient to HDU and transfuse if the parameters, give fluid challenge, transfer to HDU and transfuse if the parameters continue to worsen.
All right. Thank you.
Thank you.
Okay, can you tell me if patient had a bleeding? Was it an anastomotic leak?
Yes, ma'am. It could be an anastomotic leak, but however, the patient has no features suggestive of intra-abdominal sepsis, no fever, no abdominal pain, no tenderness, no abdominal distension. However, I'll commence serial abdominal examination and walk up the patient for an abdominal ultrasound scan. And if the patient, if I notice any signs of peritonitis or intra-abdominal sepsis, I will let you know.
Okay, patient has raised urea and creatinine. Why do you think, what might be the cause of patient's acute kidney injury?
Yes, ma'am, likely because of prerenal causes, because of decreased blood supply to the kidneys, which may likely as a result of the hypotension and hemorrhage intraoperatively that the patient had, which may cause activation of the renin-angiotensin-aldosterone system, which may subsequently result in acute kidney injury. It can also be because the patient might have developed sepsis, which may be associated also with a decreased blood supply to the kidneys, and then might have resulted in acute kidney injury.
Why do you think patient should not be operated now, rather should be transferred?
Yes, ma'am, because at this point in time, the patient does not show any signs of intra-abdominal sepsis, no peritonitis, features of peritonitis, no, at the moment, she doesn't have any teacher to get intra-abdominal hemorrhage. So that's why I think for now the patient does not need to be transfused at this point in time.
Okay, once you're trying to fluid resuscitate the patient, if patient does not respond, what would you do?
Yes, ma'am. I would transfer the patient to the HDU, place a central venous line, and monitor the patient. I would also involve the nephrologist to assess. I'll do serum electrolyte, urea, and creatinine, and then I'll administer fluids. The previous day's fluid loss. I'll restrict fluid administering the previous days and then the ongoing losses.
What else would you do? The more important one I want to hear.
Okay, ma'am. I can give fluid challenge with furosemide to see if the kidneys will.
You'll also observe. You'll do CTPA. You'll check the saturation, and then you'll go give the the Clexane, and then TED stockings. Like you have to tell me the whole scenario. Could be
okay.
Yes. What would you do if patients if HDU is full, and who are you going to talk to then? What would you do?
Yes, ma'am. If the HDU is full, I would inform my consultants, also inform the ITU registrar. I would monitor the patient closely I'll monitor the patient closely at the hospital on the ward, and then on when there's a bed space in HDU, or also request for transfer of any patient that is now stable in the HDU for my patient. And then onto the patient, there's a stable patient. Yes,
what might be the causes of shock in this patient?
Yes, ma'am. The cause of shock in this patient can be hypovolemic shock because of the ongoing shock from the ongoing blood loss. Patient can also have septic shock, likely if an anastomotic. Patient can also have if there is a deep obstructive shock, if there's a deep venous thrombosis if there's deep venous thrombosis with associated saddle embolism, the patient can develop obstructive shock.
Okay. What about any other type of shock? Patient is
the patient can also the patient can, if the patient is allergic to talc or other agents, the patient can develop.
Can you define distributive shock? What is distributive shock?
Yes, ma'am. It's a form of shock in which there is significant peripheral vasodilatation with redistribution of blood volume into the peripheral circulation, shunting blood away from the vital organ, resulting in a drop in blood pressure, reducing vital venous return, resulting in a drop in the blood pressure and perfusion and reduced perfusion of vital structures.
Okay, good. Thank you.
Thank you, ma'am.